When you do.
We are started.
Okay, great. Welcome, everyone. Good morning, good evening, good afternoon, wherever you are. Welcome to the Fresh School Health and Nutrition webinar series on the 15th of August 2017. My name is Mohini Venkatesh. I'm an advisor on school health and nutrition at Save the Children. And before we start off today's webinar, just a brief introduction on the Fresh webinar series. These are monthly presentations by leading policymakers, researchers, and implementers engaged in improving the health and education of children in low and middle income countries across the globe. You can visit the schoolsandhealth.org website for more information on past webinars and to access all of the information there, as well as on the fresh-partners.org website for more information about FRESH. We're commemorating International Youth Day, which was recently held on the 12th of August. And today's webinar is on oral health promoting strategy, integrating oral health promotion targeted at school children. We'll be hearing from Dr. Paula Moynihan, a professor of nutrition and oral health at Newcastle University and the director for oral health at the WHO Collaborating Center for Nutrition and Oral Health. And Professor Moynihan has published several papers on the topics, and we'll be hearing more from her on what it takes to include the oral health aspect of ensuring children are healthy to learn and they learn to be healthy. Professor Paula, over to you.
Okay, thank you, Mohini, and hello everyone. It's actually a real honour to be invited to present this webinar on oral health promotion and integrating oral health with general health through sugars reduction. Dental caries, commonly referred to as tooth decay, is among the most common non-communicable disease. And globally, children aged 12 on average have almost 2 decayed teeth. Now, tooth decay persists as a severe health problem in high-income countries, but in low and middle-income countries, it's escalating dramatically. And it's the most expensive non-communicable disease to treat, and therefore prevention is more appropriate and cost-effective, and control of dietary sugars underpins this. So over the next 40 minutes, I'm going to summarise the oral health status of children and present an overview of the WHO Oral Health Strategy, emphasising the links between oral and general health and the common risk factors. Then I'd like to spend a little bit of time looking at the WHO Guideline on sugars and also the research that underpinned it. And then I want to look at what data we have on sugars intake by children to demonstrate the size of the problem. Then I want to look at the broad spectrum of concerted actions that are necessary to address high sugars intake. And last but certainly not least, I want to consider how the school has a vital role to play in achieving sugars reduction and oral health promotion. The Global Burden of Diseases study highlighted that untreated tooth decay was the most common of the included 310 conditions, ranking first for the decay of the permanent teeth and 12th for the decay of the deciduous or the milk teeth. Moreover, globally, tooth decay to the permanent teeth has increased by almost 15% in the last 10 years, and so it's a prevalent disease and it's still increasing. And according to the WHO Oral Health Database, tooth decay affects an estimated 60 to 90% of school children. And the burden is higher amongst the most poor and disadvantaged in societies, so it adds to the burden of health inequality. Now, this map represents data on the severity of tooth decay across the world by country, and it's taken from the WHO Oral Health Country Area Profile project that's run by Malmö University in Sweden. It shows the severity of dental caries or tooth decay measured as the number of teeth that are decayed, missing or filled in children aged 12 by area or country. So areas with a high severity of dental caries are shown in red. Areas with a middle severity are shown in yellow. Those with a low severity are shown in blue, and those with a very low severity in green. And that includes a lot of the higher income countries, but also some parts of Africa and China where intakes of sugars remain low. However, even in the areas where there's a low severity of dental caries, the prevalence remains high, and there are pockets of high severity in the most disadvantaged communities. Oral diseases have several impacts on society and individuals. Dental diseases are costly to treat, and in high-income countries, that costs between about 6 to 10% of healthcare budgets. But in low and middle-income countries, the direct cost of treating dental diseases would exceed total healthcare budgets, and therefore much of the tooth decay goes untreated, and this means it leads to severe pain, infection. It negatively impacts on quality of life. It impacts on children's growth, their school attendance, and their performance at school. And so effective prevention is a priority. So having defined the problem of dental caries, I'd now like to move on to discuss the WHO Oral Health Strategy. And the WHO Oral Health Strategy recognises that there's an intrinsic link between oral health and general health and quality of life. The Oral Health Strategy emphasises the need to incorporate programmes for the promotion of oral health and prevention of oral diseases into programmes for the integrated prevention and treatment of chronic diseases, and it urges member states to adopt measures that ensure that evidence-based approaches to oral health are incorporated into policies for the integrated prevention and treatment of chronic non-communicable diseases. It advocates considering mechanisms to provide coverage of the population with essential oral health care, but focusing towards prevention and health promotion. For those countries without access to optimal levels of fluoride, WHO advocates the development and implementation of fluoridation programs, giving priorities to equitable strategies such as automatic water fluoridation, and also programs like school milk fluoridation programs and the provision of affordable toothpastes. The Oral Health Action Plan advocates increasing capacity to produce oral health personnel such as dental hygienists, nurses and auxiliaries, and to address human resources and workforce planning for oral health as part of every national plan for health. It's also important to consider the inclusion of oral health information into health surveillance plans so that oral health goals are set and monitored, and such goals could include monitoring of sugars intake. WHO advocates evidence-based oral health promotion, and that budgetary provisions are dedicated to the prevention and control of disease. And finally, the plan urges countries to develop and implement the promotion of oral health and prevention of oral diseases for children as part of activities in health promoting schools. And of course, this is a topic I'll be returning to later in my presentation. So to sum up the WHO Global Oral Health Strategy, oral health is integrated within the strategy of non-communicable disease prevention and health promotion, and emphasis is put on developing policies in oral health promotion and oral disease prevention, including building oral health policies towards effective control of risks of oral health, stimulating development and implementation of community-based projects for oral health prevention, with a focus on the more disadvantaged and poor population groups, and advocating a common risk factor approach to simultaneously prevent dental diseases and other non-communicable diseases. The rationale behind this integrated approach is not only for more effective use of limited resources, but it's also justified because many of the risk factors for oral health are in common with those for non-communicable diseases. For example, an unhealthy diet that's low in fruits and vegetables and high in sugars and fat not only is a risk factor for systemic non-communicable diseases such as obesity, type 2 diabetes, cardiovascular disease and some cancers, but it also increases the risk of oral diseases, including tooth decay, gum disease, and oral cancers. For example, gum disease, which is a major cause of tooth loss, has a bidirectional relationship with type 2 diabetes. Type 2 diabetes is associated with a threefold increased risk of having gum disease, and we know that gum disease impacts on blood sugar control. Indeed, treating gum disease leads to improvement in diabetic control. And this is an important consideration as the prevalence of type 2 diabetes is increasing in children in low and middle income countries. Tooth decay and obesity also have a common risk factor, dietary sugars. Dietary sugars is the cause of tooth decay, but it also contributes to excess energy intakes and causes obesity. And indirectly, through causing obesity, it increases the risk of other non-communicable diseases such as diabetes, cardiovascular disease and some cancers. Therefore, interventions to restrict sugars intake will benefit both general and dental health. So the WHO Oral Health Strategy supports the common risk factor approach and recognises that public health solutions for all diseases such as tooth decay are most effective when they're integrated with other chronic conditions such as obesity and with national public health programmes. For tooth decay to occur, you obviously need a tooth, you need oral bacteria and a sugars substrate. So the oral bacteria metabolize the dietary sugars and they produce acid. And these acids demineralize the hard tissues of the tooth. That's the outer enamel layer and the underlying dentine layer. And this demineralization over time eventually leads to a cavity developing. Dental caries or tooth decay can in part be mitigated by a lower constant level of fluoride in the mouth, because fluoride aids remineralization of enamel and it strengthens the enamel and increases its resistance to acid attack. However, decreasing sugars removes the cause of dental caries as opposed to mopping up the damage, and also reducing sugars has benefits beyond the mouth in helping obesity prevention. In view of the important role of dietary sugars and the causation of non-communicable diseases, WHO in 2015 published a guideline on sugars intake for adults and children, which was based on extensive reviews of the evidence relating to sugars and undesirable weight gain and sugars and dental caries. A reduction in free sugars throughout the life course was recommended. I seem to be on the wrong slide, just bear with me one moment. I seem to have lost a slide. Never mind, I shall just see if I can find it and then I'll get back to it. Here we go, I'm on this one. So I'm talking about the WHO guideline for sugars in adults and children, and they made a strong recommendation that the intake of free sugars should be reduced throughout the life course, and that both in adults and children, that free sugars intake should not exceed 10% of energy intake. And furthermore, they suggested reductions to below 5% of energy intake, and made a really important comment, and that's for countries that already have a low free sugars intake, that the intake of free sugars should not be reduced further. Let me see if I can, for some reason my slides have gone out of order, but I will get there. So we talk about these strong and conditional recommendations, and the WHO used the grade method to assess the quality of evidence and also to determine the strength of the recommendation. The strength of the recommendation is an indicator of the confidence that the desirable effects of adhering to the recommendation outweigh the undesirable effects. So strong recommendations are made when the recommendation should be adopted as policy in most situations. And conditional recommendations are made when there's less certainty over the evidence or other elements such as the undesirable effects, and when the recommendation probably should be adopted as policy, but there may be a need for more local debate and involvement of stakeholders for translation of the recommendation into practice. And so there was a strong recommendation for 10% and a conditional recommendation for 5%. So we're talking about free sugars. So what are free sugars? Well, dietary sugars includes all mono and disaccharides, that's glucose, galactose, fructose, sucrose, maltose and lactose. And added sugars include those mono and disaccharides that have been added to food, and the classification also sometimes includes honey and syrups like maple syrup and agave nectar. Now, the natural sugars that are intrinsically present in fruits, vegetables, grains and milk products, these sugars do not make an important contribution to the development of dental caries or other non-communicable diseases. And so therefore it's the sugars other than these that have been classified as free sugars. So free sugars includes all mono and disaccharides that have been added to foods or drinks by manufacturers, cooks or consumers, plus those sugars that are naturally present in honey and syrups, fruit juices and fruit juice concentrates. It's the intake of these sugars that should be reduced for health purposes. So if I could just flick back here. So the WHO guideline development process that led to these recommendations used a very robust development process, and it was based on the WHO Handbook for Guideline Development. It was underpinned by comprehensive systematic reviews of the evidence on body weight and sugars. So the process involved identification and prioritisation of the research questions and the outcomes, retrieval of the evidence through systematic review, assessment and synthesis of the evidence, and then formulation of the recommendations. And the WHO Nutrition Guideline Guidance Expert Advisory Group subgroup on diet and health worked with the WHO in technical consultations and reviewed the evidence, drafted the recommendations, and considered the strength of the recommendations based on the desirable and undesirable effects of the recommendations, the quality of the evidence, the values and preferences of the recommendation in different settings, and the costs of the options available to public health officials and programme managers in different settings. And the entire process was overseen by the WHO Guideline Review Committee. So as you can see, it was a very thorough process. So just a little bit on the evidence on sugars and tooth decay, and the systematic review on this was conducted by myself and Sarah Kelly from Newcastle University in the UK. And we found that 42 of the 50 studies that were identified in children reported a positive association between sugars intake and tooth decay. And this covered studies in high, middle and low income countries. We found moderate quality evidence that increasing intake of free sugars increased risk of dental decay, and that limiting free sugars to below 10% of energy or calorie intake reduced the risk, but it didn't eliminate dental caries. And we also found very low quality evidence, but still some benefit of further reductions to below 5% of energy. And this was particularly thought to be important in protecting oral health throughout the life course. So, how do current intakes compare with these WHO recommendations? Well, for everyone in a population to consume less than 10% of energy as free sugars, the population average would need to be in the region of about 5% of energy, and that's equivalent to 10 kilograms per person per year. But when we look at data on current sugars intake, we see that they really do exceed this. It's estimated that the total consumption of sucrose alone averages 24 kilograms per person per year. And this graph shows per capita sucrose intake data based on data from Sukden, and it's by region of the world. And we can see that Africa and Asia have the lowest consumption levels, 16.8 and 17.3 kilograms per person per year, and America and Europe have the highest levels, averaging 36.7 kilograms per person per year and 43.8 kilograms per person per year. So sucrose consumption in developing countries, particularly in Asia and to a lesser extent the Middle East and Africa, is rapidly increasing. And these data on sucrose don't provide the whole picture, because they exclude sugars from other sources such as corn syrups, fruit juices, honey, and mono and disaccharides other than sucrose. So there are very few data on the levels of intake of free sugars, of total free sugars in the diet. And most of the data we have are from high-income countries, such as those shown on this slide. So this is data from the UK National Diet and Nutrition Survey, which is for free sugars, and it shows that free sugars provide over 15% of energy in adolescence. There are data from the US that show that in adolescence over 17% of energy is coming from added sugars. But there is a pressing need for more comprehensive data on free sugars intake by populations, especially those from low and middle income countries, where the intake of sugars, sucrose and other free sugars, and also sugared sweetened beverages is also increasing. Now, I did manage to find some data on the intake of sugars from low and middle income countries, and this is by no means an exhaustive list. Data show that Thai people consume on average 30 kilograms of sugar per person per year, which is equivalent to 82 grams per day or 16% of energy. FAO data indicate that sugar's consumption in Malaysia averages over 5 times the WHO recommendations, and in India, average intake of sugar, jaggery and sugar from sugared sweetened beverages equates to approximately 25 kilograms per person per year, or 14% of energy. In Iran, per capita sugar consumption exceeds 30 kilograms per person per year, and in Kuwait, sucrose and sweeteners alone provide over 100 grams per day. So based on the WHO figures for energy requirement, 5% of energy is equivalent to 19 grams per day for a 6-year-old and around 25 grams per day for a 10-year-old. So as you can see, the intakes of sugar in low and middle income countries are exceeding the WHO recommendations. So where's all this sugar coming from? Well, the sources of free sugars in the diet will vary country to country, but in general there are some key dietary food groups and foods that provide a lot of sugar. And these include the sugared sweetened beverages, and it's not just the fizzy drinks, it's the carbonated and still drinks, fruit-based drinks and sweetened milk. Fruit juices, including the 100% fruit juices, confectionery, sweets, candies, chocolates, biscuits and cakes, manufactured breakfast cereals, sweetened desserts including yogurts and sour milk products, and also many savoury sauces. And to provide an estimate of how much free sugar is obtained from different food sources, I have compiled this table. And this table lists the dietary item, the standard portion size, and the amount of free sugars that you would get in that standard portion size. And this is based on methods for free sugars estimation that we've developed at Newcastle University. So a teaspoon of sugar would provide 5 grams, a heaped teaspoon of honey 13 grams, the amount of maple syrup that you would use to top pancakes 33 grams, an average small serving size of a cola drink that you would get at a fast food outlet 45 grams, so that's already double the daily limit. Chocolate, sweetened chocolate milk 32 grams, a small serving of a lemonade at a fast food outlet, 23 grams, a 200 ml carton of orange juice, 20, the average amount of condensed milk added to coffee, 15 grams, and a muffin-style cake, 24. And then I've got some more items here. A sweet plain biscuit, 5 grams. A donut, 11, the grams is missing. A small chocolate bar, 15 grams. An average serving of ice cream, 15. A small pot of yogurt, 13. A granola or an oat cereal bar, 14. A tablespoon of sweet chili sauce, 10. Many salad dressings, around 6 grams per tablespoon, and the average portion size of a tomato ketchup sauce, 5 grams. So as you can see, sugar's in an awful lot of foods and in quite high amounts. It's not easy to exceed the recommended thresholds. So if sugar's intake is going to be brought in line with the WHO recommendations, considerable action is required. The onus shouldn't be just on individuals reducing consumption. We need to produce less, to import less, manufacturers need to use less, we need to market and advertise less, advise to eat less, and eventually consume less. Implementing such strategies takes effort and time, but these upstream approaches are absolutely fundamental to sugar's reduction. If we put all our efforts down into the more downstream approaches, I don't think we'll ever succeed. The prevention of oral and other non-communicable health problems requires stronger food policy in many countries. So this slide shows the actions to reduce free sugars intake. National policies on sugars intake in line with the WHO guideline for sugars are now needed. Countries need to have clear nutrient profiling models to enable the determination of food and drinks that are high in sugar, and I'm going to talk more about this in a moment. Fiscal pricing policies that target items high in free sugars, such as sugared sweetened beverages, are advocated by WHO. And another approach is to endorse or require mandatory reformulation of foods to lower their sugars content or to reduce portion sizes. We also need more stringent regulation of advertising and marketing foods and beverages that contain free sugars, and better education of both consumers and professionals so that all have nutrition literacy with respect to sugars. National health education campaigns are also needed because these raise awareness and they provide the support for sugars reduction. And of course, there are many opportunities for school-based approaches, and I am going to talk more about this later. But first I want to look at fiscal pricing policies, because WHO advocates the taxation of sugar-sweetened beverages. And in a report of the WHO technical meeting on fiscal pricing policies in 2015, it was concluded that there's reasonable and increasing evidence that appropriately designed taxes on sugar-sweetened beverages would result in proportional reductions in consumption, especially if aimed at raising the retail price by 20% or more. Moreover, taxing a product can send out a very strong health message to consumers that the product isn't healthy, and also taxing schemes can be used to generate revenue to fund health intervention. I now want to talk about nutrient profiling, because this seems to be fundamental to a lot of the actions that are needed to reduce sugars. Nutrient profiling is the classification of foods according to their nutritional composition for promoting health. It enables classification of foods as unhealthy or healthy based on cut-off values for saturated fat, trans fatty acids, sodium or salt, and sugars. And it has a variety of applications. It can be used to define banning marketing to children, for making health claims, for product labelling, for information and education of the public of what is and isn't healthy, and also to guide the provision of food in public institutions such as schools, as well as to help identify targets for fiscal measures. It's a helpful tool to use in conjunction with interventions aimed at improving diets in a region or a country. And the WHO is working with international experts and partners to provide guidance in developing and adapting nutrient profile models. And the aim is to harmonise the nutrient profile model to develop a consistent and coherent public health nutrition message. So in 2015, the WHO Regional Office for Europe released a regional nutrient profile model to use in member states. And the WHO regional office in the Western Pacific has since worked with member states and experts to develop a model for their region. And it's this model I'm going to talk a bit more about. The final model consists of 18 foods that have been categorised according to thresholds for saturated fat, trans fat, sodium, and total and added sugars. But I'm only going to mention the thresholds for sugars. So according to this nutrient profile model, there are certain foods that are prohibited from being advertised and marketed to children. And these include confectionery, cakes and biscuits, and energy drinks. But if I break down those categories in a little bit more detail, the prohibited items include chocolate and sugar confectionery, energy bars, sweet toppings and desserts, cakes, sweet biscuits and pastries, energy drinks, and instant and pre-mixed tea and coffee. Now, at the other end of the scale, there are foods that are always permitted to be marketed to children, and these include fresh and frozen fruits, vegetables, and legumes. For other foods, marketing is prohibited if the product exceeds certain thresholds for the various nutrients, and here I've shown the levels of sugar above which marketing of a product to children is prohibited. So for savoury snacks, things like crisps, nut mixes, etc., if there's any added sugar, because the limit per 100 grams is 0 grams, then that's banned. For juices, smoothies, coconut juice, if the total sugar exceeds 5 grams per 100 grams. For milk drinks, if there's any added sugars. For other beverages, also any other sugars. For breakfast cereals, if the total sugars is above 10 grams. For yogurts and sour milk and similar, total sugars above 10 grams. And the same for ready meals or composite dishes. For salad dressings and dips, again, if any sugars added, so added sugars above 0 grams, and the same for processed fruits and vegetables, as many dry fruits sometimes have sugar added during the drying process. Okay, so I want to move on now and consider school-based approaches, because many children are growing up in an obesogenic and a cariogenic environment, and the school should certainly not be such an environment. The Nutrition Friendly School initiative aims to provide a framework for ensuring that integrated school-based programs which address the double burden of nutrition-related ill health, and to build interconnecting and ongoing work and programs of work with various agencies and partners. And these include the FRESH initiative, the UNICEF World Food Programme, Child Friendly Schools, WHO Health Promoting Schools, to name a few. The Nutrition Friendly School Initiative programs therefore should also consider sugars reduction and oral health promotion within their programs, as it's possible to integrate measures to address sugars intake and oral health in schools with school-based measures to combat obesity in childhood. And an example of this is the Ending Childhood Obesity WHO report. The report on the Commission on Ending Childhood Obesity included an implementation plan, and many of the elements of this are of direct relevance to schools. The report highlights that between 1990 and 2015, the number of overweight or obese children increased globally from 31 to 42 million and from 4 to 10 million in the Africa region alone, where undernutrition coexists. And actually many elements of the Ending Childhood Obesity relate to the promotion of a healthy diet that's low in sugars. And so such a diet will also protect oral health. So I want to go and look in a little bit more detail at school-based approaches. And school-based approaches to free sugars reduction need to be underpinned by government action in setting policy. They need to consider both the school environment and the school curriculum, and they require capacity building, training and support to deliver school-based intervention to reduce sugars intake. In their report on ending childhood obesity, WHO highlighted that governments need to accept primary responsibility for taking actions and implementing effective policies for schools to reduce sugars intake, which of course is essential for combating both obesity and tooth decay. And national nutritional guidelines, including those for free sugars, should be set by governments, as these are going to form the foundation for nutrition standards for food in schools. Setting national standards for foods in schools should involve a whole government approach, working across the relevant sectors and considering both all non-communicable diseases, including obesity and oral health. And governments have a role to play in providing those guidelines on nutrient profiles used to identify the unhealthy foods and drinks that are too high in sugars, and in implementing the WHO recommendations on marketing of foods and sugar-sweetened beverages to children. I'll talk a little bit more about that in a moment. Governments also need to consider resource provision for implementation of policies on sugars reduction, including capacity building and supporting research into effective means of reducing sugars intake in the school setting, especially in the low resource settings where multiple nutritional problems exist. The WHO Oral Health Strategy advocates that governments provide support fluoridation schemes where appropriate. For example, milk fluoridation schemes have been implemented in Thailand, and government should also set national targets for time-bound reductions, not only in obesity, but also for tooth decay. So what about the school environment? The school food policy set by government should include standards for meals provided in schools, including setting thresholds for the food provided. For example, you could say no more than 5% of the calories in school meals come from free sugars. Policy should eliminate the sale of foods and beverages that are classified as high in free sugars based on national or the WHO nutrient profile standards for what classifies as high sugars. And this should also be applied to foods and drinks brought in to school from home and elsewhere. The school needs to ensure that healthy choices that are low in free sugars are made available, and WHO advocates making provision of free access to safe drinking water an absolute priority for schools. In addition, with respect to oral health, the WHO Oral Health Strategy encourages to ensure adequate fluoride, as already mentioned, but the school also provides an excellent environment for children to learn and practice oral hygiene. I said I'd want to talk a little bit more about marketing of sugars to school children, because WHO urges that government ban any forms of marketing of products high in free sugars in schools, and children are highly susceptible to the marketing of foods and drinks high in free sugars, and they need to be protected from such marketing. And this has been recognised by the WHO in their document Set of Recommendations on Marketing of Foods and Non-Alcoholic Beverages to Children, which states that settings where children gather, such as schools, should be free from all forms of marketing, and that government should implement regulatory mechanisms to avoid sponsorship, advertising and marketing of foods and beverages non-consistent with healthy dietary practice, which of course includes those high in free sugars. It should be noted that marketing includes exposure through social media. Children are exposed increasingly to this form of marketing. But marketing also includes sponsorship and advertisements in schools, in textbooks, in newsletters, in school supplies and sports equipment, and even sponsored events. None of these should make reference to products that are high in free sugars. Moving on to look at the school curriculum as a means to support action to reduce sugars and oral health promotion, government should develop food and nutrition education, including that of sugars, and that involves both the health and the education sectors. Areas relating to sugars and health that could be included in the core curriculum are how sugars cause tooth decay, how sugars cause obesity, different types of sugars, free sugars, the sugars content of different foods and drinks, the maximum levels of sugars associated with health, and how to read food labels and front of packet labels. The curriculum could also include food preparation classes, providing children with the skills necessary to prepare foods that are free or low in free sugars, and also lessons on good hygiene, including oral hygiene, with toothbrushing sessions built into the school day. But of course, education needs to be age-specific and skills-based. And in order to actually realise this, then we need the capacity to deliver. And this will require training of existing teachers, staff and school cooks, and also the inclusion of sugars and oral health topics in the training curricula for future professionals. Despite evidence of a clear benefit of sugars reduction, evidence on what intervention modes and what active ingredients, i.e. behavioural change techniques that are pragmatic, acceptable and culturally appropriate for different populations is actually lacking. Interventions to reduce sugars that address both behaviour and the environment, which are sustainable, scalable and transferable, are needed in low and middle income countries. And attention needs to be given to ensure that the interventions are developed in ways that are acceptable and culturally sensitive. To develop a Sugar Smart programme, all stakeholders need to be engaged with the process, and this includes the Ministry of Health and Education, of teachers, school food providers and food vendors, pupils and parents, as well as the community and relevant professional organisations. The WHO school policy frameworks provide guidance, but there actually is a need for more research into what interventions work in low resource settings. Well, I can see that my 40 minutes is just about up, so I'm going to draw this presentation to a close by concluding that tooth decay is the most prevalent non-communicable disease, and it's increasing in many low and middle income countries in line with other non-communicable diseases. The WHO oral health strategy is integrating oral health promotion with strategies to reduce other non-communicable diseases through the common risk factor approach, and free sugars is a common risk factor for both tooth decay and obesity. WHO recommends limiting free sugars to below 10% and preferably to below 5% of energy, but available data show that the free sugars intake by children in many countries exceed these recommendations. School-based interventions form part of a broad spectrum of upstream and downstream actions that are necessary to reduce sugars intake. And school-based approaches need to be government-driven. Governments need to provide guidance, support, resources and capacity to deliver such interventions in school. School-based approaches to sugars reduction and oral health promotion need to consider both the environment and the content of the curriculum, and need to involve all stakeholders, parents, pupils, teachers, cooks and vendors. They need to be appropriate, feasible and acceptable. With respect to oral health, water is safe for teeth, and promoting its consumption in place of sugar-sweetened beverages will also aid obesity prevention. And schools should also consider promoting toothbrushing programmes and teach oral hygiene as part of the wider health agenda in schools. So schools-based approaches to reducing sugars consumption will help to prevent tooth decay. Tooth decay is a totally preventable disease, but I think that school-based approaches to sugars reduction will have many benefits beyond the mouth. Thank you for your attention. Okay, so that brings me to the end of my presentation.
Thank you so much, Dr. Paula. That was a fascinating presentation, which gave us a very comprehensive overview of, one, the WHO strategy to integrate oral health into general health programming through reduction of sugar intake, and what can be done through schools to address this issue. I also have today with us Dr. Yuka Makino from the WHO headquarters, who works with countries in capacity building of national oral health strategies, and she will be facilitating the Q&A session. Yuka, if you're on the line, if you could unmute yourself and...
Yes, first of all, Professor Paula, thank you very much for very comprehensive information on both global oral health epidemiology, especially children, and also introducing WHO oral strategy, and also like information on sugar guideline, and also like some like guidance on like how to conduct like a school-based oral health promotion, especially like through controlling sugar reduction. So that we had several questions. So I'd like to ask you one by one.
Okay.
So the Professor Porter, like from the Mohini, so in terms of resource allocation, where would you recommend more emphasis dairy toothbrushing drills in school, or in annual oral health surveillance in school, or equally both?
So resource allocation to, I missed the first point.
Yes.
So, could you just repeat the question?
Yes, resource allocations.
Yeah.
So in terms of like there is like a limit of like amount of the resource.
Mm-hmm.
Where would you like emphasis more for the resource allocation for toothbrushing in the school setting, or like annual oral health surveillance in school setting? What is like a most like important intervention or like a program to focus on? The first priority is what do you think of?
Well, that's quite a difficult thing to choose between surveillance and toothbrushing. And I think one of the important things is that it is important to monitor and evaluate efforts. So I think that surveillance is absolutely crucial in underpinning interventions, because it enables you to set the goals for your and measure success. If you don't do any form of surveillance, how do you know if you've achieved your goals? But I think it's almost impossible to choose between those two, because you obviously need the surveillance to monitor current oral health, and then of course you need initiatives like toothbrushing to actually do something about it. But I think toothbrushing is it is important, it should be included in schools, but it's actually a fairly downstream intervention method. If it's supported by, if you have more upstream interventions to reduce sugars, those perhaps ought to be given priority first.
So the Mohini, is it clear?
Yes, thank you, Yuka. And perhaps I had a few other questions, but you could go to some of the other participant questions before taking up my other questions in the interest of time.
Okay, so from the Hilary, what is the country with the greatest success in reducing sugar intake? And then like what did they do?
Yes, well, this is interesting, because I don't think you can actually sort of let's just say which approach is the best, because it might vary country to country. But there's all sorts of evidence to back up many approaches. There's evidence to show that taxing of sugar sweetened beverages would be an effective intervention means. So that's quite a high level upstream measure. There's also a lot of evidence that shows that marketing and advertising works, and therefore if advertising and marketing sugary foods is working, then actually actions to do something about that should work. But we don't yet have the data to say, well, what is the impact of bringing in those recommendations on banning marketing to school? We're not there yet. So a lot of recommendations have been made, and I think it's really important that we do evaluate their impact so that we get this information on which are the most effective approaches. But I would say that we need to focus on the upstream methods. We need to change things at policy level, at country level, because if we put all our efforts in at the level of the individual, we won't succeed.
Yes, related that question, I think like the Jacqueline's question also related this like Hilary's question. So do you have a guidance or example of successful programs that have worked with both school and community on combating sugar sales to children? Because like from Jacqueline, that they often have the challenge of vendor targeting sales of sugary food to children outside of like both school, and children purchase outside of school and bring into the school.
Yeah, I know that in my own country, the UK, that sugar sweetened beverages were banned in schools, and vending of sugar sweetened beverages are banned in school, and the impact of that is currently being evaluated, but I don't think we have those data out there yet. So I'm not quite sure whether I can answer that question with respect to schools-based approaches, so, I must apologise. I know that all of the strategies that I've mentioned in my presentation have been sort of evidence-based, that there is evidence to support them. But I try to have a look at this question now. So this is the question asking about, do I have guidelines or examples of successful programs that have worked with schools and communities? Have the challenge of vendors targeting sugary foods outside of schools? Yeah, I mean that, I don't have any examples of people that have tried to address that, but I have seen there have been moves to actually look at and bring in policies that actually cover the geographical location around where the schools is, and to say, we need to work with those vendors so that the environment surrounding the school is also a healthier one. There has been some work in New Zealand where they actually got the pupils involved, and the pupils went round to the vendors within the region proximity close to the school and encouraged the school vendors to start actually getting rid of some of the sugary soft drinks and promoting healthier choices. But what we won't have is a proper evaluation of that. I think there is a need for more research into what will work well in different settings.
Thank you, Professor Poller. And then actually another comment from Karen that she would like to mention that not only question but wash is important in this context. And then actually today's discussion also Dr. Belamos, who is involved in the Fit for School, also participating in this webinar. If Dr. Bella, if you have any comment or any idea which you would like to share with us, could you give us some comments?
Yes. Thank you very much. I'm also much involved in oral health care programs in Southeast Asia, and we have much promoted really daily toothbrushing, and not only promoted but working with the government to implement it as daily routine activities. And we can see when it's implemented, it's a question of implementation quality. So if the quality of implementation is well, you get 40% reduction in new caries, which is quite amazing. I think that has been in several countries. We have done this and we have also published this. So that is at least something, and it will, you also expect that will establish a habit in the children, which they will also use for their entire life.
Did you say you had published that?
Yes, we published that. We published that recently. Excellent. In BMC. Yes. I think I'm very much in favor also in really looking into how to reduce sugar intake, and it's a pain to see specifically in Southeast Asia the increasing consumption of sugar on school ground, and I think a very good steps in some of the countries now to really ban sugar on school ground. But the question is always, you have the policies, the question is the implementation quality. You have many countries where it's just not implemented, so you have wonderful policies. The question is how to really get that into place.
I think that's what we really need to research, and I think it's engaging with pupils and parents. So often these policies come sort of top up down onto schools, and I think working with schools and working with parents and pupils to actually get them engaged and wanting to see a reduction in sugars is perhaps the way forward. But I'd welcome your views on that.
Yeah, I'm not so sure if that's. I mean, I highly support that, but I can see that I have spent years of my life in really trying to do that. And it was so frustrating. And I think what I can see now is starting to really go into strict implementation rules and sort of monitoring systems where schools have to report if they do it, and if that will be sort of controlled, so that they will also know people are following up. So that might be part of it. I think it's still not easy to really get that, and I think good examples would be great. And another thing I think is also to link up with this drinking water initiative, to link up with the entire Wash in Schools community, where access to drinking water is one of the target areas within the SDGs for Wash in Schools. And I think that's super important, specifically also for the nutrition and health side, to promote that as well. That's super important to link up and work with the WASH world.
And I think it's also important because it enables us to give out a positive message. You know, we're saying drink water, you know, obviously it has to be first of all provided, and the safe water has to be provided. But I think people like positive messages, and promoting, you know, clean, safe drinking water is going to really benefit dental health. It will hopefully reduce the intake of some of the other drinks. And so, yes, it's a priority.
Yeah. But there are many places where Coke is still cheaper than water. And this is a scandal. And that's in Southeast Asia quite often the case, where Coke is cheaper than water, and people drink Coke like water. Yeah? It's hard to see that, but that's very much the case. And there's a lot of addiction to sugary drinks. So I think it's a big problem.
Yeah. Yes, I think change isn't going to happen overnight, but we've got to keep the effort up.
So, Dr. Vera, thank you very much for sharing your knowledge with regard to especially like a wash and water and drinking issue. And then we also had a final question from Dr. Duck. So Professor Pollard, are you aware of any studies reporting on level of student knowledge or skills related to oral health or consumption of sugars?
No, I'm not aware of any studies. That doesn't mean that there aren't any, but I'm not aware of any. I think that the amount that students are taught as well, and pupils in schools are taught, varies considerably. And this is why I suppose I was suggesting there should be a core curriculum, so that the knowledge and the skills, there's a basic level that everybody should get during their schooling. But no, I'm afraid I don't know of any studies that have measured knowledge or skill. So I can't answer that for you.
Yeah, so could you give any comment if Dr. Bera has?
Yeah, perhaps we've done questionnaires, and we could see that the knowledge on oral health was very high. People knew because they had the Colgate programs since grade 1, and they grow up basically with Dr. Rabbit, and they know that they should not consume so much sugar. They should know that they should brush their teeth. But when you see what they were drinking, and they were still drinking Coke, and they were still not brushing their teeth. You did and you looked, and they were not. You could see in the mouth that there was never a toothbrush in, but they could tell you all of the details which they were supposed to do, and that is very much frustrating to see. That also brought us to the point that you really have to offer the activities within the school, because the knowledge alone is not changing behavior.
Well, we've known, that's been known for a very long time. I think it's the first block. You need the knowledge, but translating that into behavior takes many more steps. But I still think that everybody has the right to know, and everybody should be given the information. But I really do think that if we're going to change intake, that we need some more of these upstream strategies to address sugars.
Yeah.
Thank you so much, Bella and Paula and Yuka as well for facilitating the Q&A session. I'm afraid we have run out of time and we haven't had the chance to go through all of the questions, but it's been a great presentation and excellent discussion on today's webinar. I know some of my colleagues are keen to connect with you, Dr. Paula, and others, and I hope we can keep this discussion going. I'd like to conclude the webinar once again by thanking the presenters and the participants for this excellent session today, and also announcing that the next webinar, monthly webinar, will be on the 15th of September. The title of the webinar and the presenters will be shared with you in the coming days. So do look out for more details that we'll share with an invitation for next month's webinar. Thank you very much and wish you a great evening, a great day wherever you are.
Thank you.